while I'm on my phone. Um, and I am going to try and get on a different computer. So hold on one second. I'm actually going to mute myself for a sec and get some help with this. So just hang tight for 1 second. Okay, I'm back. I've got I'm setting up another computer, but in the meantime, I think in the interest of time and not having too many devices go at once, I'm going to just introduce you from the phone. And then I will try and get on a laptop, but if I don't, I can use the phone the whole time, luckily. This is really bizarre issue that we're having. But anyway, do you have any, before I introduce you, do you have any questions? Like, are you okay with the WebEx? Are you?
I think so. As long as you can see the slides, like, okay, let me try to, okay, hold on 1 second. Yes. Okay.
Yeah,
Okay. Perfect. Okay. That's all
that's great.
that's what I was most worried about, just because I couldn't
Awesome.
really tell. Okay.
Great. Thank you. I'm really excited to hear about this book. So let's see, it is 12 o'clock. Let me give one more minute for a lot of folks tend to sign on right at the moment. So let me give maybe one more minute and then I will introduce you. And usually we leave some time so we stick to the 1 hour time, and you know, however, whatever time is left at the end of the talk, we can open it up for questions and answers, and we usually have a nice like Q&A time. And I can help moderate that. Hopefully I won't be on the phone still, because then it becomes a little difficult for me to see hands raised, but we will persevere. Okay, it's 12:01, so in the interest of time, I'm going to go ahead and get started. Okay. Hi, everyone. Welcome to Ethics Grand Rounds. I'm Johanna Crane in the Department of Bioethics, Alden March Bioethics Institute here at Albany Med. I want to apologize for a little bit of a tech issue that I'm having. So you may notice that I'm talking to you from my phone. That will hopefully change shortly, but there's something going on with both my desktop and my laptop at this point. So that's why I'm doing this from the phone. But regardless, it is my very great pleasure to introduce our speaker today, who is Dr. Author-Thurka Sangaramoorthy. So Dr. Sangaramoorthy is a cultural and medical anthropologist with over 25 years of ethnographic research experience across the Americas, Africa, and the Caribbean. Her work examines power dynamics in care and global health systems, focusing on migration, infectious diseases, and environmental health disparities. Dr. Sangaramoorthy is currently chair of the Department of Anthropology at American University. She leads NIH-funded research on structural racism affecting farm workers and contributes to the Global Health Future Alliance on Climate Resistance. She previously coordinated the U.S. refugee response in Sudan and South Sudan from 2022 to 2024 for the U.S. State Department. She has also authored 3 books on healthcare access, ethnographic methods, and HIV/AIDS, with a forthcoming book on Black women living with HIV. And her insights have also appeared in major publications, including the Washington Post and Forbes. She holds a PhD from UC Berkeley, UC San Francisco, an MPH from Columbia, and completed postdoctoral training at the CDC as a research scientist. So Dr. Sangaramoorthy, we are so glad to have you today. Can you still hear me? Your video just went off.
Oh no, okay. I can hear you.
Okay.
You're no longer in person. I just see your see your picture. Can you hear me or see me?
I can't see you, but I can hear you fine, and we can see your slides fine.
I can see you.
Wow.
Okay.
Oh, and Pierce, okay, my colleague Pierce can see you, so that's good.
Okay. So it might be just your phone, perhaps?
It might, yeah, let's say that it's just phone, since seem to be having tech issues on any tech item that I touch this morning or this afternoon. So,
okay, great.
So you go ahead, and I can hear you just fine and see your slides.
Okay, great. Wonderful. Okay. Hopefully I can move through the slides. Good afternoon, everyone. Thank you for inviting me to speak today as part of your Ethics Grand Round. As Johanna so kindly introduced me, I'm Author-Thurka Sangaramoorthy. I'm professor and chair of the Department of Anthropology at American University. I'm also an affiliate professor at Addis Ababa University in Ethiopia. So today I'll be sharing insights from my long-term ethnographic research on healthcare access and delivery in rural settings, focusing specifically on immigrant communities. This presentation draws from my book, Landscapes of Care, which examines the intersection of immigration, health, and rural precarity. I'm assuming most of you in the audience are either healthcare providers, ethicists, and students, so you're intimately familiar with the challenges of delivering care. What I hope to offer is a perspective that centers the experiences of rural immigrant communities who often remain invisible in our healthcare discourse, yet whose lives reveal profound truths about care, community, and survival in marginalized spaces. So just to give you an overview of how I've structured the talk, I'm going to delve a little bit into my research background and methodology. I work with various different methods as an interdisciplinary person, but this work in particular is entirely ethnographic and from an anthropological point of view. So I wanted to kind of explain a little bit about that, especially for those of you who may not be as familiar. I'm going to really ground my work in the theoretical framework around precarity and explain a little bit about, where I'm coming from, how I thought about this concept, especially throughout this work, which is essentially over 10 years, right, that I did this work. I'm going to then tell you a little bit about some of the key findings that are all interrelated, talk a little bit about things that may be of interest to you in terms of thinking through ethical implications of this work, and then hopefully have a little bit of time for discussion after some concluding thoughts. Excuse me. So my research explores a fundamental question. How does care unfold in rural settings among people navigating complex intersections of immigration status, health needs, and rural precarity? There are 3 primary objectives that guide my work. First, examining how rural health systems influence immigrant experiences. 2, gathering information on rural immigrant communities and their specific health needs. And 3, contributing to a better understanding of immigrant health within rural health systems. I feel that this research contributes to some literature that's already out there, but it also fills a critical gap as rural immigrant health remains understudied despite growing evidence of significant disparities and unique challenges in these communities. I conducted my research on Maryland's Eastern Shore. It's a region that provides a compelling case study of rural immigrant health in America. And let me explain why this location is particularly significant. The Eastern Shore represents a largely rural peninsula separated from Maryland's urban centers by the Chesapeake Bay. Despite being just a few hours from Washington, D.C., our nation's capital, and Baltimore, many communities here exist in relative isolation. This region has experienced dramatic demographic transformation driven largely by labor migration. Between 2000 and 2019, for instance, the foreign-born population increased by over 90% in many Eastern Shore counties. This rapid change has reshaped local communities in profound ways. Migration to this area is primarily driven by employment opportunities in three key industries. First is seafood processing, particularly blue crab picking. Second is poultry production and processing, as well as agricultural work, including both seasonal and year-round positions. What makes this region particularly interesting is that it represents what immigration scholars call new destination for immigration. Unlike places with long-established immigrant communities, the Eastern Shore has experienced immigration as a relatively recent phenomenon, creating unique challenges for both newcomers and existing residents. This rapidly changing socio-demographic landscape has placed significant pressure on local health systems that were already struggling to serve rural populations adequately. These systems now face the additional challenge of meeting the needs of culturally and linguistically diverse communities. My methodological approach has been deeply ethnographic, beginning in April 2013 and continuing through multiple research phases. Ethnography involves immersing oneself in communities to understand experiences from the inside out. I've conducted over 90 formal interviews with diverse participants, including 25 health providers ranging from physicians and nurses to community health workers, immigrant community members from various backgrounds, including Mexican, Guatemalan, Haitian, and other nationalities. I spent a lot of time with social service providers as well, advocates, and local officials. But formal interviews represent the only one dimension of ethnographic research. Equally important has been extensive participant observation, logging over thousands of hours in multiple settings, homes of immigrant families where I witnessed daily health challenges and coping strategies, service organizations providing support to immigrant communities, health clinics serving rural and immigrant populations, migrant housing, including agricultural labor camps and seasonal worker accommodations and motels. The sustained engagement over years across diverse settings had allowed me to triangulate findings and develop a nuanced understanding of how care unfolds in these communities. The image you see here captures one of the many informal conversations conducted during fieldwork. These unstructured interactions often revealed insights that may have never emerged in formal interview settings. Ethnographic research requires building trust over time, often years, especially with vulnerable populations. This process has been gradual but essential for understanding the complex realities of healthcare access and delivery in these communities. You might wonder why focus specifically on rural immigrant health. So I want to explain the key objectives that have guided this research. First, I aim to examine the influence of rural health systems on immigrant experiences. Rural healthcare faces distinct challenges from urban settings, including provider shortages, limited specialized services, and transportation barriers. These challenges are often magnified for immigrant communities that are already navigating cultural, linguistic, and legal obstacles. Second, this research addresses a significant gap in our knowledge. Despite the growing presence of immigrants in rural America, we have remarkably little data on their health needs and experiences. Most immigrant health research focuses on urban populations, while rural health research often overlooks immigrant communities. Third, I wanted to contribute to a better understanding of both immigrant health and rural health systems by examining where these domains intersect. This intersection reveals important insights about healthcare access, delivery, and policy that might remain invisible when studying either domain in isolation. The image shown here depicts a rural health clinic setting that serves immigrant populations. These spaces often become important community anchors, providing not just healthcare, but also social connection and support. What makes this research particularly valuable is that it challenges dominant narratives about both rural America and immigrant communities. By centering the experiences of rural immigrants themselves, we gain new perspectives on healthcare equity, access, and resistance that can inform better policy and practice. So I want to kind of ground this work in the framing around precarity. To understand the lived experiences I've documented, I employ the theoretical framework of precarity. Precarity often refers to enduring vulnerability and uncertainty resulting from racialized socioeconomic forces. For rural immigrants, this precarity manifests in multiple overlapping dimensions: legal status, employment insecurity, healthcare access, housing instability, and social marginalization. Rural populations also themselves experience increasing precarity through economic disinvestment, infrastructural abandonment, and resource extraction, creating shared conditions of vulnerability that connect rural and immigrant experiences despite their different positions. What's particularly revealing is how these shared conditions of uncertainty and disposability lead to mutual dependency and care within these communities. When formal systems fail, people develop alternative networks of support and care. This framework shifts our understanding of health and healthcare in important ways. Rather than viewing healthcare solely as a service delivered by professionals within institutionalized settings, we see it as an embedded in complex social relationships and everyday practices that extend far beyond clinic walls. Importantly, my research privileges diverse immigrant voices, capturing the heterogeneity of experiences rather than presenting a monolithic narrative. These stories challenge dominant representations of both immigrants in rural America in our public discourse. So my research, I'm going to really talk about 5 interconnected themes that I'm going to discuss in detail. First is rapid rural immigration and how immigrants form an essential yet marginalized workforce. Immigration beyond legality, that is moving past reductive legal and illegal frameworks. Rural healthcare challenges, the systematic abandonment of rural health infrastructure. And then, as the title of the book, Landscapes of Care, really thinking about these alternative networks and strategies that emerge in response. And finally, ending with thinking about community and resistance, and especially about how communities demonstrate resistance and political agency. So the way that I'm going to kind of go through this, which I hope makes sense, is that often the first slide before I talk about some of these findings will really draw from narratives from the book. So I'm just going to read, and I know the slides are going to look a little heavy in those slides in particular, but I hope my reading will be helpful. There are a few things more enjoyable to Marylanders than sitting with family and friends, tearing into a bushel of blue crabs coated with the local seasoning, Old Bay, and washing it down with ice-cold natty bows. Eating blue crabs in the traditional manner is not for the faint of heart, or for those who prefer eating with utensils and white tablecloths. In restaurants and homes, people pile steamed and seasoned blue crabs in the middle of a table covered in paper. Then, using small mallets, knives, and bare hands, diners break open the hard shells and extract the juicy meat inside. It's a messy experience, but also a deeply communal activity, where conversation flows freely, stories are shared, and social bonds are strengthened over hours of collective eating. Yet most people rarely consider how this beloved local delicacy is produced by female migrant workers, primarily from Mexico, who perform the grueling work in crab processing plants, picking meat for hours in challenging conditions. These women working on temporary H-2B visas sustain an iconic Maryland industry while remaining largely invisible to those enjoying the fruits of their labor as a celebrated social ritual. Here on the eastern shore of Maryland, we see a dramatic transformation of rural demographics that mirror larger trends. Between 2000 and 2019, many Eastern Shore counties experienced a 90% increase in their foreign-born population. This isn't just a statistic. It represents real people making difficult journey in search of work and opportunity. This migration is primarily driven by labor recruitment in three key sectors. First, seafood processing, particularly blue crab picking, which traditionally employed maritime poor African American women from local communities, but now it relies almost exclusively on seasonal Mexican women workers on H-2B visas. Second, poultry production has become increasingly dependent on immigrant labor, as shown on the image in this slide. Companies like Purdue, headquartered on the Eastern Shore, actively recruit workers from Haiti, Guatemala, and other countries for their processing plants. Some people might think that the poultry industry in this country is largely located in the Midwest, but it's actually a U-shaped corridor that ends on the Eastern Shore and in Maryland and Delaware in particular. Third, agricultural work continues to rely heavily on migrant labor for harvesting fruits and vegetables. Many farm workers follow seasonal patterns, arriving from Florida and directly from their home countries. And for those who may not think of Maryland as largely rural and dependent on agricultural work, it is heavily dependent. Maryland was a slave-holding state. And for centuries, it's relied on agriculture. It's one of the main sort of economic industries in Maryland, first starting with cotton and then tobacco, and now mainly other kinds of produce. What makes this situation complex is that immigrant workers have become essential to U.S. rural labor markets while often not being welcomed or treated well. They occupy a paradoxical position, simultaneously essential to the local economy and socially marginalized. They're hyper-visible as foreign others, yet invisible as community members with needs. This isn't simply a story of exploitation, however. Many immigrants I spoke with actively choose these arrangements, making strategic decisions within constrained circumstances. As Ximara, a crab picker from Mexico, told me, we're here because of the work, because in Mexico you don't earn anything. Similarly, Maria explained how her work in Maryland enabled her to build a home and fund her children's education in Mexico, despite the personal sacrifices involved. It's important to understand that immigrants' experiences in these rural settings are more nuanced than simple narratives of integration versus exclusion would suggest. These experiences vary considerably across nationality, race, gender, and legal status. Haitian workers often face different conditions than Mexican or Central American workers, while documented and undocumented immigrants navigate distinct though overlapping challenges. The rapid demographic change has also generated tensions around resources, cultural differences, and belonging that manifest differently than in urban areas with longer histories of immigrant settlement. These dynamics fundamentally reshape how we should understand both immigration in rural America in the 21st century. Lude, who migrated from Florida every year to pick and pack tomatoes, recounted the time when a local health group carried out breast cancer screening for migrant women. When they arrived at the camp, they proceeded to screen only Latina women and refused to allow Haitian women to participate. When questioned by Lude and others, healthcare workers stated that Haitians didn't meet the inclusion criteria for the screening, insinuating that they didn't fit the category of migrant women because they were Black. Lude and several Haitian migrant workers became upset and told the health workers to leave. A critical insight from my research is the need to move beyond frameworks that reduce immigration solely to the question of legal status. In healthcare context, immigration status has become the primary lens through which we understand immigrant health, leading to restrictive policies and practices. This approach privileges certain immigration stories while erasing others, particularly those who don't fit into these neat categories of legal versus illegal. Lude's story is an example that illustrates this point powerfully. This incident around breast cancer screening reveals how even well-intentioned healthcare services can reproduce racial hierarchies and exclusions. When the healthcare workers refused to screen Haitian women, they weren't simply applying neutral criteria. They were enacting a racialized understanding of who counts as a migrant deserving of care. This racialization of immigration status reveals how Blackness is often rendered incompatible with the category of immigrant in American consciousness. Haitian migrants, despite sharing similar migration patterns and labor conditions with Latinx workers, are frequently excluded from both migration or migrant services and broader immigrant advocacy because of anti-Black racism that positions them as fundamentally different or other. For healthcare providers and ethicists, this raises important questions about how our systems might perpetuate these exclusions, even unintentionally. When healthcare access becomes entangled with immigration enforcement, profound ethical dilemmas emerge for both providers and patients. Moving beyond legality means developing more nuanced frameworks that account for how race, gender, language, and other aspects of identity shape immigrant experiences of seeking and receiving care. It also means recognizing how racialized hierarchies operate, even within immigrant communities themselves, creating complex barriers to solidarity and mutual support. I was nervous and excited to spend the day with Elizabeth, a nurse practitioner who runs the local mobile health unit. Her mobile team was the only one of its kind and offered care to those living in the furthest, most remote corners of the Eastern Shore of Maryland. Our first stop was a rustic restaurant on a grassy knoll. The restaurant was closed, but we weren't there to dine. Instead, it was a pit stop to get organized, notify the various seafood houses of our arrival, and secure permission from owners to set up the mobile clinic on their property. The medical files were disorganized. The workers' names on the list provided by the seafood houses often didn't correspond to the names on the files. I peeked at the medications that the team hoped to dispense on this trip. They varied, ranging from skin creams to pain relievers. Cuts, scrapes, rashes, and skin infections were common among women working in crab processing. Some women also suffered from allergic reactions to vapor, salty water, bleach, and other chemicals used in crab processing. In addition, women experienced minor injuries, chronic pain, tendinitis, and myalgia from long hours picking crab in crouched positions. Elizabeth explained the plan for the rest of the day. I worried about how much of her schedule would get done given half the day had already passed. Finally, perhaps sensing my anxiety, she leaned over and told me she needed to get the van back within 24 hours. Otherwise, she would pay for an extra day. Noting and seeing my surprise, Elizabeth explained, I use my personal credit card and then get reimbursed. Otherwise, no one would get care. Local residents often describe the Eastern Shore as a land that time forgot, a reference to both its bucolic charm and its social and economic marginalization. This mirrors broader perceptions of rural America as flyover country, regions rendered invisible in national policy conversations despite their essential contributions to food systems, energy production, and cultural heritage. This quote captures a pivotal moment during my field work when I accompanied Elizabeth, the nurse practitioner running the only mobile health unit serving migrant workers on the Eastern Shore. What's particularly revealing about this moment is how Elizabeth casually mentioned using her personal credit card to rent the mobile clinic van. It wasn't presented as extraordinary. It was simply what had to be done to provide even minimal health care to access to isolated communities. The medical implications of this arrangement are profound. Without Elizabeth's personal financial interventions, dozens of migrant workers with conditions ranging from workplace injuries to untreated chronic diseases wouldn't have access to care. The crab pickers we visited that day presented with various occupational health issues, infected cuts from crab shells, chemical burns from cleaning solutions, chronic pain from repetitive movements, and respiratory problems from prolonged exposure to processing plant conditions. Elizabeth carried a makeshift pharmacy of medications because she knew there wasn't an accessible pharmacy within a reasonable distance. She performed triage for severe cases, knowing that referring patients to specialists often meant they simply wouldn't go due to transportation barriers and concerns around cost. The rural context is crucial here. The physical isolation represented by driving through remote areas, stopping at small convenience store and community with no medical facilities, sitting with rural residents in their everyday spaces, all illustrate the geographic barriers that shape healthcare access. The 24-hour time limit wasn't just about van rental policies. It represents the compressed time frame in which Elizabeth had to deliver care to numerous scattered communities across a vast rural landscape. The quote encapsulates the crux of rural healthcare precarity. Without individual providers going far beyond their official duties and using personal resources, the system simply fails to function at all for the most vulnerable populations. David, a local physician, explained, "I have an undocumented gentleman who came in with diabetes. There are patient assistance programs through the pharmaceutical company if you're poor, but if you're undocumented, you're nothing. So I got the reps to give me medicine for him." He continued, describing the pushback he received. "He ended up in someone else's care. They called me and said, 'What are you doing to this man? He can't afford this medicine. He doesn't pay for it.' They said I couldn't continue to do this for him. I said, 'Why not? Nothing's stopping me from continuing to do this for him.' So I have an arrangement that when he runs low, he comes by." When I inquired what kind of pushback he got, he responded, "Put him on regular insulin, which he has to do every 4 hours. I have him on a pen that costs $400 to do once a day, and he's doing well. He can't test his sugar before he eats or on a sliding scale of insulin because he's in the field. Insulin has to be refrigerated. What are you supposed to do? Have a little fanny pack of ice as he goes through the chicken houses that are 110 degrees? So you have to be creative about the environment in which they exist. It's difficult at best, but it's difficult for everybody. The hardest problem for them to deal with is that I give him free care. And the point is that he has to purchase his medication or services. No matter what I do, I feel like I'm putting Band-Aids on things that need stitches." This brings me to my central concept in my work, Landscapes of Care. Rural health and healthcare delivery defy conventional logics of space and time. Care unfolds across dispersed geographies, through improvised networks and in unexpected places. The concept of landscapes helps us better understand this context, not just as physical terrain, but as social, political, and ethical topographies that people have to navigate to secure care. What's particularly fascinating is how this landscape emerges through interactions between immigrants and providers. Rather than viewing care as a one-way service delivered by institutions, I observed intricate webs of reciprocity and innovation. For example, I spent time with Nurse Rhonda, who modified her approach to chronic disease treatment for migrant farm workers. She explained, "I can't treat as aggressively as I would with high blood pressure or diabetes because if they stop some of these meds, they're going to stroke out. So I have to say, okay, we'll start this. Did you need more? Follow up with your doctor when you get back home because this will be enough." And I focus on the $4 medicine or the $10 medicine for 3 months. Rhonda practiced what I would call therapeutic rationing based on her intimate knowledge of drug costs and her patients' mobility patterns. Meanwhile, farm workers like Carlos strategically scheduled their medical appointments for time on the Eastern Shore, explaining that the care they received in Maryland was far superior to what was available anywhere on their migration route. Mary, a nurse practitioner in a small, impoverished community, developed an elaborate bartering system with her immigrant patients. When I say they can pay me with whatever their product is, I actually mean it, she told me. Anna, who made tamales, would bring them in exchange for care for her undocumented family members. Local watermen paid with crabs in the summer and oysters in the winter. These arrangements weren't just about economic necessity. They created relationships of mutual obligation and recognition that transcended the typical provider-patient dynamic. As one provider explains, sometimes you create a whole different system outside the system just to help people get what they need. Isabel, an undocumented immigrant who cleaned houses, developed her own network of care through her employers. I worked for very good women that let me clean for them. The people who I assisted were doctors' wives, lawyers' wives. One family paid for my insulin at Walmart for 8 months. Another paid for my schooling fees for 2 years. Landscape of care also includes strategic information sharing, where Merlan's husband was fired from the poultry plant after missing work due to injury. Word quickly spread through the Haitian community about which supervisors were more understanding about medical absences. This knowledge became a vital resource for workers managing chronic conditions. What emerges is a landscape that's improvisational, yet it's patterned, informal yet structured by its own internal logic of reciprocity and practicality. These networks form not as charity, but as mutual aid, recognition that everyone is vulnerable within systems that prioritize profit over well-being. Junior and his parents came to Maryland to join an uncle who had been working as a farm worker for years. Junior was 20 years old at the time, and he intended to study. But instead, he deferred his dreams and quit community college to work and help his family make ends meet. Like many Haitians who came to the area, Junior's first job was on the assembly line of the local poultry processing plant. Junior found his experience at the poultry plant deeply traumatic. Still now, when I think about it, I hate the fact I started working at the chicken plant. It wasn't a good experience. I didn't like the people. I didn't like the way they treat me. I didn't like the way the supervisor was treating me. Yet within this challenging environment, Junior found a way to assert himself when he learned English. I think that's the first time I said no, is the first time things started to get better. I remember all the guys in the line started treating me different because I can talk to them now. They no longer talk behind my back because I answer when they say something. So it doesn't mean I don't have friends, but most of the guys in the line didn't treat me good at all because they felt like as Americans, they were superior. They're Black American and you're Haitian. So the white people are treating them low and then they're treating you low. It's a circle thing. My research privileges immigrant and rural knowledge systems that often remain invisible in healthcare discourse. These communities possess sophisticated understandings of how to navigate precarious situations and create care networks where formal systems fail. This isn't to romanticize these alternative systems, which emerge from the necessity in the face of US healthcare systems that are critically inadequate, often racist, and systematically exclusionary for many immigrants. From this perspective, healthcare access becomes a terrain of political struggle, not simply a service to be delivered, but a fundamental right to be claimed and fought for. Throughout my fieldwork, I witnessed how struggle manifests in everyday practices. Farm workers in labor camps created informal transportation networks to overcome geographic isolation. As Fabian, a Haitian farm worker, told me, we just stay here. We don't know anything else. Yet within these constraints, workers developed systems to share rides to medical appointments, pooling resources to overcome the deliberate spatial isolation of agricultural labor. Mexican women in crab processing, limited by strict temporal constraints, developed collective strategies, designating certain members to obtain prescriptions for several workers during limited clinical hours. Providers participated in these acts of resistance too. Dawn, a nurse practitioner, lamented how the system had become top-heavy with its administration and very bottom-poor with services. She created informal referral networks, connecting immigrants with specialists willing to provide discounted care outside official channels. Ernesto, a local charity care provider, discusses how he deliberately avoids verifying legal documentation when helping his clients access social resources. They all have false social securities, he said. When I'm filling out an application, I say to them, do me a favor when you get home. This is the social you have. Not that I think I can run into trouble, because I'm sure everything else I'm filling out is fine, so I don't worry about it. And if I call an agency, they'll say to me, I need their social. And I'll say, I can give you their birth date. All right, but you don't have their social? No, I don't. I try not to say they don't have a social. This administrative resistance represents a profound challenge to the exclusionary systems. Perhaps most powerfully, immigrants themselves refuse the logic of disposability embedded in both immigration and healthcare systems. Daniel, describing poultry work like a slavery job, but you get paid for it, joined others in creating systems of mutual support when supervisors denied bathroom breaks or medical attention. These practices emerge from clear analysis of structural conditions. As one Haitian community later told me, we try to be united. A lot of other people don't like us. They don't like Haitians. This recognition forms the basis for collective action that transformed the landscape of care from mere survival to solidarity and dignity. These findings raise several important ethical considerations for healthcare providers and institutions serving rural immigrant communities. First, the principles of justice in healthcare must extend beyond formal equality to address systemic barriers that disproportionately affect rural immigrants. This means reconsidering how we allocate resources and design delivery systems. Second, traditional models of medical ethics may require adaptation in precarious settings where standard assumptions about patient autonomy, continuity of care, or treatment options may not apply. Third, healthcare institutions bear responsibilities toward marginalized rural populations that extend beyond direct service provision to include advocacy, community partnership, and systems redesign. For bioethicists, my research suggests the need to develop frameworks that account for structural conditions, not as external factors, but as constitutive elements of healthcare itself. For healthcare providers working within rural immigrant communities, I suggest several approaches. Cultivate cultural humility and structural competence that acknowledges the complex barriers these communities face. Partnering with community organizations that already have established trust and relationships. Advocating for systemic change while finding creative ways to provide direct care within existing constraints. For healthcare systems and institutions, invest in rural healthcare infrastructure, including transportation solutions and mobile health services. Developing inclusive policies to provide care, regardless of legal status. And build care models that reflect community needs and strengths, including support for community health workers. Then coming to some concluding thoughts. Landscapes of Care, I think, offers a conceptual framework for understanding how care unfolds in rural immigrant communities. Not as discrete encounters within medical institutions, but as complex navigations of social, political, and economic terrains. By centering immigrant voices and experience, we gain crucial insights, not only about the challenges that these communities face, but also about their resistance, their creativity, and their agency in securing care, despite systemic barriers. The ethical imperatives emerging from this research, to me, are clear: to develop more responsive, equitable systems that recognize the dignity and humanity of rural immigrant communities, to challenge frameworks that reduce immigrants to their legal status, and to build solidarity with marginalized communities in their struggles for justice. As healthcare providers, ethicists, and students, there's definitely a crucial role to play in this transformation. And I hope the stories and insights I've shared today contribute to your important work. Thanks so much. And I look forward to our discussion.
Thank you so much. Can you hear me okay?
Yes, now I can even see you.
Okay, great. Thank you. Thank you so much, Thurka, for that wonderful talk. And thank you, Faria, for giving me your laptop that is functioning so that I can see and be seen and speak and hear everything. So thank you, everybody, for your patience with the tech issues. So we can open it up to questions now. If folks can raise their hand electronically with the little hand raise signal at the bottom of your button at the bottom of your screen, and I will call on you. I think I will go ahead and ask a first question, though, if I may, which was, I really appreciated this talk so much, and I saw a lot of what you spoke about resonated with a small project that I've done that's involved interviewing providers in community health centers in different states, some of which also serve rural immigrant populations, only one of which was technically like designated as a migrant health clinic. But what those providers talk about, a lot resonated, but the thing I was going to ask about is when you talked about how providers kind of do this improvisational work of figuring out a workaround that might be a little bit different than the standard of care or the ideal that will work for a particular patient, because I definitely heard providers talk about that, or talk about, there were providers in leadership positions. So sometimes they were speaking about their kind of frontline staff saying, well, technically we should probably do X test, but if we do that, then they might need a colonoscopy, and there's no way for them to access a colonoscopy. Or they should get this lab result, but like this lab test, but it costs so much. It's either like they're going to have to choose between that and paying their rent. So like, how do you navigate that? So I guess my question would be, did the providers that you interviewed, did they struggle with kind of navigating that, making it work for their patients versus upholding kind of a broader standard of care?
I definitely would say that the folks that I worked with, it's interesting because I think, so I've worked in immigrant communities for a very long time prior to 2013 when I started this. And this was really the first time I'd really worked in a rural community before. I was really interested in my work in rural communities in particular started when I was at CDC. And we would do disease outbreaks in fairly rural settings. And I just didn't have the bandwidth or really the time to kind of consider some of the things that I was seeing. And when I came to Maryland, I was really interested about, on thinking about the Eastern Shore. And I went to actually sort of talk to people, mainly providers and other researchers. And even though I had, over a decade of experience working in immigrant communities, the first questions that they asked me is, do you know anything about rural health? And I thought, okay, and I had to kind of admit that I didn't know what that meant. And they said that you can't understand immigration if you don't understand rural health. And so come back when you've actually sort of looked at this. And for a long time, for years, I didn't understand what that meant. I think I really didn't understand until I actually started writing the book. And I think in some ways, what they were telling, what David said, that quote that I read, it's difficult at best, but it's difficult for everybody. And at least the providers, this wasn't new for them, right? This improvisation wasn't new. It was how rural communities have always gotten on. It's how they've always survived, how they've always supported each other. And I'm not romanticizing it again, but immigrants just get folded into this mix, right? So this bartering system that I talked about, for instance, is a major kind of improvisation that happens. And it doesn't just happen with immigrants, it happens with the local communities, right? The watermen. The first time I went to David's office, he opened this large refrigerator and it was just full of crabs. And I was like, what is this? And it's like, that's my payment. That's how I get paid, right? And then so that there's these seasonal variations of how bartering actually happens. It's amazing. And I think that's part of it, in a sense, is that this is how it's always been. And that's something that I also have to kind of contend with is I think most of our training is grounded in urban sort of understandings. And even though many of us do work in various different locations, I think there's something really profound about the fact that, you know, what does even a social safety net even mean in these settings, right? What does that actually mean? For me, it was just literally a handful of providers that were doing their best to kind of meet just an okay standard of care, and that was okay. And it's really, really difficult, right? It's difficult when you can't see anyone, when you have to upfront your money. You know, the first time the mobile clinic van showed up to pick me up, it was just a minivan. And I was like, okay, I don't know what this is, but, and off we went. And, yeah, it's a constant state of improvisation, constantly, of doing things that often would be considered not conventional, sometimes perhaps maybe not even, you know, legal, right, in the formal sort of system. But it's just how things work. It's just how things have always worked. And immigrants just sort of, I'm not saying just sort of, but it's just it is a little bit more complicated with immigrant populations, especially during certain, you know, certain periods of time, and definitely on the Eastern Shore, which is very politically conservative. And so there are lots of nuances there, but this is something that people will tell you that they've done for a long time. So I don't know if that answers your question, but yeah.
Yeah, no, it does.
It's what I, in my book, call Band-Aid care, right?
Yeah.
Which is, you know, when he says, you know, I'm constantly feeling like, you know, I'm putting Band-Aids on stitches. And this notion of Band-Aid, right, I argue, is something that we see as a temporary fix to a much larger problem when he says that. But that is the solution, right? That has become the permanent solution, right? Is this patchwork care, and it's not really even a patchwork in the traditional sense of how we think about it.
Yeah, no, thank you. That does answer my question and resonates so much with also lots of work that you've done and I've done and others have done in global health too. So seeing those domestic global health parallels are, I think, really important too. This is not American exceptionalism here, right? This is, yeah. Great. Thank you so much. Are there other folks who want to ask questions? I'm going to open it up.
Thanks so much for a really quite a moving talk. I really appreciated it. You ended the talk on a note of solidarity and the need for that. So I sort of, I guess I can think about solidarity in terms of just solidarity at a political level and the political will to provide, you know, seek equity here. Then just even at an individual level, and how to sort of cultivate that sense of solidarity. I mean, especially, you know, we're living such different lives within our society, within these lines, and especially with just all the political tensions now. But I mean, I guess I was curious, I mean, just how you sort of, I was wondering, I guess, I don't have like a particular question, but just how you think about that solidarity. Are you fairly hopeful about it, or do you feel like you hit a wall, or what are some things that you sort of envision might help sort of promote that solidarity? Just wondering.
Being in DC, I feel like I've aged 10 years in the last 3 months. So I don't know, this is not, it's not, I don't know if I can respond as, you know, but being around students always helps. But I think really the interesting thing to me here is, you know, I've studied patient provider relationships for a long time in various different settings. And I think what is so fascinating to me in this context. Again, this is an incredibly politically conservative areas where they will literally tell you we don't want them here, yet are so incredibly dependent and thankful on many regards. So there's this juxtaposition that is a constant sort of tension. And that in itself, I think, to me, again, trying to be reflective over the years of the kinds of things that I had in mind when I entered this space. And then I think over years, what I also saw was, again, that question, right? I guide my work through this question of what I was first told: if you don't understand rural health or rurality, you will not understand immigration. And I really that sat very heavily with me. And I think this is where the notion of precarity wasn't something that I went into the field with. It was really something that came up as I started writing through this, and particularly the book manuscript. And I think what I mean by that is that the solidarity isn't really apparent in all visible sort of circumstances, right? There are rural, sometimes many politically conservative folks, right? And then you have immigrants. And not to say that they're not politically conservative, but it's just this juxtaposition that's constantly in tension here. Yet this notion of need is so vast that it really connects people in a profound way that I think is something that I'm trying to kind of think through this notion of precarity, and how in these sort of circumstances, how people, regardless of their position status, right? I'm not saying this equalizes people at all, but what I'm saying is that actually brings people together, this sort of common notion of being without, being left behind, being used, their lands being extracted, their bodies being extracted, right? There's this common sort of understanding of what that's like. And I think that is sort of, to me, what I would consider that political terrain of advocacy and mutual sort of aid that I'm talking about. I'm not saying it equalizes people. I'm not romanticizing it. It's very complicated. But I do think that this common notion of precarity is what binds people to do for each other when no one else can, where no system actually exists in their mind. So I hope that, to me, that's still hopeful.
Yeah.
To me, that I draw hope and strength from that, right? And so I think could there be something that's much more transformative? Sure. And I think that will take a much longer period of time. But I think for me, in these spaces, like, this is also resistance, right? And so I think that's what I'm most hopeful about, is that it comes from places like this and spaces like this.
It's helpful. I mean, yeah, this notion of precarity is interesting. I mean, have you sort of thought about it in relation to something like vulnerability? And do you see precarity as something very quite distinct or capturing a different nuance?
Yeah, and I think that's what I was trying to say. So thank you for clarifying that for me. So precarity is this, it can be this all-encompassing thing, right? It's so heavy that there's no way out sometimes. It's constant vulnerability, it's constant uncertainty. But what I'm trying to argue is that there's hope in there, right? It's the things that people do for each other, right? Under these constraints. That is also, to me, part of precarity, what precarity actually brings, right? It's not all bad. That there is like hope that can come from this as well.
Thank you very much.
Great, thank you. I think we have time for one more question, probably, if there's someone else who has a question.
I could go. It's not a very well-formed question, but I was just thinking through the concepts. By the way, I want to enjoy the talk. Thank you. So it sounds like, you said that you can't really understand immigrant care without understanding rural care. It sounds like you could almost say the opposite, like you can't really understand rural care without understanding immigrant care, or really understanding precarity, of which one manifestation of it is like the immigrant migrant experience, right? I guess though with precarity, I wonder, so is it just precarity that's doing the work here? Like, I mean, if you were to go to a rural area with a lot of precarious folks, or people living in precarious conditions medically, but it's not a very
Yeah.
sorry, a large portion of the population, do you think you'd find like mostly similar stuff, or these analytical concepts would carry over really well? Or do you think you'd find different stuff? Is there like an intersectionality between immigrant experience and precarity? I kind of just like, how do those two things play together? Because now I wonder if it might not be helpful to tease about a teeny bit just to see like how much is the precarity we're not doing, I guess. I'm curious if you say.
And I think that's the thing though. I think, I'm also trying, again, as someone who came into this work, not having really thought about rural landscapes at all, right? Again, to me, it's even thinking about Maryland as largely rural, which it is, right? It's really kind of, it's interesting because I think in the American consciousness, especially a lot of political discourse, in the day, during the years of COVID and even now, there's this landscape of the rural as this there's a particular kind of national consciousness that we have. And when we do that, what we don't, it's largely white, it's largely, et cetera, racial, socioeconomic, certain kinds of health effects. And I'm not denying any of those, but what I'm saying is many of these rural communities are incredibly diverse. And they always have been, right? Whether it's immigrant communities, whether it's Native populations, whether it's African American populations, it's been incredibly diverse for a very long time. I think what I'm trying to kind of maybe think about is also this notion of what I would consider to be rapid immigration, which is happening in various different places. It's happening in rural New York. It's happening, rural Pennsylvania, right? So I think that there's a shift that's happening that is incredibly rapid in a way that people aren't necessarily perhaps thinking about. And I'm also just wondering, I do think that this kind of thing exists, not to like juxtapose immigrants with Native populations, for instance, but really kind of thinking about, precarity in different ways that carry a very similar kind of tension that I was talking about, right? Like who belongs here? Who was here first, who has the right to be here? How do people sort of sustain economies that are largely depleted? How do they stop? How are these populations actually sort of contributing to local culture, to the population, to the economy, et cetera? And so I think that there's always been this kind of tension in rural areas that I personally think are incredibly diverse. And always have been. I think this is also just kind of raising some consciousness in a way that not necessarily that I was learning alongside my participants, right, in thinking through this. And I think these are, again, some thoughts that I've had over the years. And it will be really interesting to see what the next 10 years will bring in a lot of these areas. Do people largely move out and move to spaces that are perhaps they think more hospitable? I'm not sure. So I think that this is also something to watch. I don't think that this is static. I think these are going to be really important sort of discussions to have. But I think my main point was to really think about the diversity of rural spaces in a way that I don't think that we actually talk about.
Great, thank you. That's super helpful, and making me also think a lot about where I live and in new ways. So I appreciate that. Well, we are at the 1 o'clock hour, so I'm going to close us out by saying thank you once again, Thurka, Dr. Sangaramoorthy. I'll be formal since we're here in medical school and people really insist that we always...
The other thing is that the book is open access, so it's fully accessible.
That is great.
Yeah, and it's free. So that was my intention, and
that's wonderful.
And it's really meant for for people to really, it's really unfortunate that I wish we had a more robust sort of scholarship around rural issues.
Yeah.
Not that mine is anything penultimate, but at all. But I really wish that we had a little bit more depth and breadth and paid a lot more attention. So yeah.
Well, thank you for reminding us about the open access piece of it. And I also want to say, I think I misspoke during your intro and said that you had that your book on Black women living with HIV is forthcoming, but that book is out. So
No, it's
it is? I thought it was out.
a process. Book publishing isn't, oh gosh. Anyway, that's a
Okay,
whole
so I didn't
different-
misspeak. All right,
that's a
good.
whole
I was like,
different
wait a
thing.
second. All right. I'm familiar with that work, but I guess I got overly excited thinking that I already had the book in my possession. But I will soon.
Thank you so much. This was so great. And thank you for the wonderful questions. I really, really enjoyed it.
It was a great talk. And so thanks for joining us. Hang in there in DC.
Thanks.
I'll follow up over email.
Sounds great. Have a great day, everyone.
Okay,
Yeah, thanks so much.